of Dermanar. For this, I invite the today's session master of ceremony, Dr. S.V. Kavita, the Associate Professor of DVL from Gandhi Medical College and Hospital, Hyderabad. Madam, over to you.
Thank you, sir. Good evening, one and all. I now invite our TS Iadvl President, Dr. DBN Muthi, sir, to give welcome address.
Good evening, everybody. I welcome you all for this maiden Dermanar, which is a platform for sharing the knowledge and improving our skills. And I wish you all a very happy new year. And I wish that this Dermanar program should become a great success and see that it reaches all the delegates in TSIADVL and across the country. I wish this a great success, and I declare this Dermanar open. And now I ask Dr. Kavita Madam to take care of the proceedings. Thank you once for giving me this opportunity.
Thank you so much, sir. I now invite our first speaker, Dr. Yogesh S. Marfatia, sir, Professor at SBKS Medical Institute, Vadodara, and is our past national IADVL president and also president for ISSTD and AIDS. And he was the chief editor of IJSTD and AIDS journal. He received many awards and honors, like Sardarial Memorial Award for the best paper. So over to Marfatia, sir. Kindly take over, sir.
He is also the coordinator of SAG dermatophytosis also.
Good evening, one and all. I am pleased that Iadvl Telangana has taken this initiative of Dermanar, and I feel privileged because I am like an opening batsman for this particular webinar.
You are opening batsman for our house also, sir. Iadvl house. Office. First right, office in India.
So my topic is also very properly selected, that is skin and HIV interaction. First slide. Yes. So be proud to be an Indian IADVLite. Yes. Next. Forward. Yes. So we all talk of corona. So like corona, HIV is also spiky. It has got 72 knobs to penetrate into host cell. Next. So what are the peculiarity? I would at the outset, first I would like to discuss some peculiarity of HIV. So this particular virus is heterogeneous and genetically diverse in biologic, serologic, and molecular features. It is lymphotropic, and we all know that it attacks CD4 plus helper cells. Remember that these CD4 plus cells or T helper cells are present in more than 2 dozen cells of the body, including half a dozen cells in skin itself. This particular virus, we cannot eradicate it. So this is incurable. Why this is incurable? Because the virus persists in sanctuary sites, most of them being resting memory T cells having very long half-life, and these dormant viruses are not affected by antiretroviral therapy. Virus evade immune response, and even though antibodies are present, they are not preventing viral replication, and there is continuous high-level viral replication. And unfortunately, this virus is mutagenic and its replication is error prone, leading to drug resistance and difficulty in preparation of vaccine. Still today, we don't have vaccine. Next. Yes. So I will not enter into this in detail, but the thing is that why dermatologists are in HIV right from the beginning? Because major mode of transmission in past, present, and future is sexual and will be sexual, right? And that is why we are there as a dermatovenerologist. Next. And another important point is next. Dermatologic manifestations are very much common, and almost 90% of the cases will have dermatologic manifestation. Next slide. Yes. skip this. Uh, Cutaneous manifestations can occur through all stages of HIV infection, and these dermatologic manifestations include inflammations, inflammatory conditions, infections, disorders. They can serve as a diagnostic marker of not only HIV but opportunistic infection as well. Many times, severe opportunistic infection present for the first time in skin. It has got specific prognostic significance, particularly in if CD4 count and plasma viral load estimation facilities are not available. Next, please. So let us discuss in detail skin and HIV interaction. Yes. So dermatologic manifestations are cosmetically disfiguring, having tremendous impact on mind and body both. Uh, they may be atypical, response to treatment may not be adequate, right? And I mean, most of these manifestations, of course, clear spontaneously with currently dispense combination antiretroviral therapy. Fortunately, now the policy is test and treat. And in test and treat era, skin manifestations now are replaced by ART related adverse drug reactions, endocrinal and metabolic changes. And but still, role of dermatologist is crucial in all stages of HIV management. Next. Yes. So skin has got specific immune surveillance systems comprising of antigen presenting Langerhans cells, fibroblasts, megakaryocytes, basophils, all are CD4 bearing cells and thereby primary target of HIV. T lymphocyte, even keratinocytes produce cytokines, and ultimately lymph node plays a crucial role. So this is a skin immune surveillance system. And in HIV, this system is disrupted. There is reduction in epidermal Langerhans cells, and these promote HIV binding and entry into target cell. Next. Yes. Interestingly, prepucial skin consists of lot of Langerhans cell, which is CD4 receptor bearing cells, and that is the reason why uncircumcised males are more likely to catch HIV, and circumcision is recommended as HIV prevention strategy. Another interesting point is cutaneous delayed type of hypersensitivity is indicator of cell mediated immunity, and in HIV, particularly with immunosuppression, these cases are energy, and these particular energetic people will develop symptomatic disease at a higher rate irrespective of CD4 count. Like we all know that there may be negative tuberculin test in presence of florid tuberculosis in HIV. Next. Now, let us go through different manifestations. So, it can be infectious, which include acute exantheme of HIV disease. See, very much interesting. Right from after the entry, there is something known as seroconversion illness. Previously, now it is known as acute exantheme of HIV disease, in which maculopapular rashes occurs with the flu-like illness. So skin is involved right from the early stage. Then there can be herpes zoster, chickenpox, EBV, CMV, human papilloma virus, hepatitis B, C, like that. We will discuss some of them in detail as well. Next. So there is bacterial infection, particularly staphylococcal infection in more common in children, typical and atypical mycobacterial infection, bacillary angiomatosis we were not knowing previously or not studying, now we have started talking it in HIV era. Fungal infection, tinea, I mean, irrespective of HIV, we are sort of having a lot of issues. Candidiasis, even simple lipophilic fungi like malassezia cause issues in HIV positive cases. Arthropod infections, scabies, dermodicidosis, even leishmaniasis. We have seen florid leishmaniasis in HIV. Next. So this is just to show my case of bacillary angiomatosis. You know that it is caused by cat disease organism, that is Bartonella, and it occurs at a low CD4 count, and there can be one or multiple red, purple, I mean papules and nodules, and you have to do histology and Worthington study. Now we use, of course, azithromycin. Next. Yes, cutaneous tuberculosis. Any non-healing ulcer. Whenever you see non-healing ulcer over skin or lymph node area in HIV cases or in patient on antiretroviral therapy, it can be tuberculosis. You have to think it as a DD. And now, of course, this net-based test or PCR are easily available, which was not available in during our time when HIV had a peak. Next. Yes, dermatophytosis extensive. Of course, we see it irrespective of HIV. Of course, see interestingly, steroids suppress immunity and cause extensive dermatitis. And HIV is, of course, you know that it is an immunosuppressive condition. Next. Yes, candidiasis. We have seen a lot of candidiasis. What is more important is esophageal candidiasis, and the complaint of the patient will be dysphagia or retrosternal pain like that. That is more important and more diagnostic or AIDS defining illness. Next. Now coming to non-infectious conditions. So series of non-infectious conditions occur in HIV positive cases like ichthyosiform dermatitis, dryness, eczema, right? Seborrheic dermatitis. We have seen more seborrheic dermatitis in cases as compared to normal cases. Severe classic seborrheic dermatitis affecting scalp, nasolabial fold and other areas. Psoriasis. We have seen wet psoriasis, extensive psoriasis, psoriatic erythroderma in HIV positive cases. Fortunately, ART has a great role in resolving those psoriatic cases. Ritter's disease. We all know that, yes, it is a keratoconjunctivitis, arthritis, and skin, and all Ritter's manifestations many of us have seen. Next. So then pruritic eruptions of HIV. See, these are very much and important. Patient complaints of itchy papular lesions or excoriated lesion. There are various causes. Try to differentiate it. Don't put a broad labeling of pruritic papular eruption, whether it is follicular or non-follicular. Follicular includes eosinophilic folliculitis, demodicidosis, staphylococcal folliculitis, or even pityrosporum folliculitis. Non-follicular include papular, eczematous, then papular PPE, and of course, there is a pruritus related to HIV without any eruption. That is also possible. Next. Forward. Yes. So this is a case of uh, PPE, papular pruritic eruptions. I have discussed the causes. I have discussed differential diagnosis. Don't forget prurigo nodularis, insect bite reaction, and try to pinpoint it. And even antihistamine, and even we have treated such cases with dapsone. We have seen dapsone as well. Next. Forward. Yes. So this is interesting. Immune reconstitution inflammatory syndrome. Fortunately, now there is a test and treat policy, and we have started treating cases as a very high CD4 count. But initially, we were treating cases as a low CD4 count, or patients were not aware and they were coming with low to very low CD4 count. We have seen cases coming with 510 CD4 count, right? So what happens in immune reconstitution syndrome? So it is nothing but a paradoxical deterioration in clinical status in patient on ART, right? Having satisfactory viral control of viral replication and even improvement of CD4 count. This happens because previously diagnosed or incubating opportunistic pathogen, they started immune system started reacting to them, and as a result of that, this occurs, right? And what we have seen commonly was TB, herpes simplex, herpes zoster as IRIS, and this appears after 8 to 12 weeks of initiation of ART, and particularly when CD4 count at this time of starting of ART is very low. So the message is that whenever patient come late with low CD4 count, or whenever there is treatment failure, first thing you have to do is, to look for opportunistic infection, to treat opportunistic infection, and then start ART. to prevent immune reconstitutional inflammatory syndrome. And the cutaneous manifestations are, of course, easy to treat, but sometimes CNS complications, CNS TB can occur as a part of IRIS. So, best strategy is that whenever your patient is having very low CD4 count, first detect and treat opportunistic infection and then start ART. Next. Yes. Then you can see pigmentary disorders. You can see lot of adverse drug reaction. I will show you some pictures. You can see something like neoplasm, Kaposi sarcoma, and you can many miscellaneous conditions. Even PRP, severe PRP, immune thrombocytopenic purpura, pityriasis rosea, atypical, photosensitivity. So whenever you see any the dermatologic condition with unusual manifestation, unexplained manifestation, think of HIV. Even today, you can pick up some HIV. We have picked up lot of HIV, many of us. Now, of course, there is lot of awareness and HIV has gone down. And the next group is adverse reactions due to antiretroviral therapy. Next, yes. Then other conditions. Sorry, go to previous slide. Previous, go back. Other conditions include, okay, next. Yes. So specific mucosal manifestations. Yes, like this is very much important. Like gingivitis, periodontitis, linear gingival erythema, very much interesting. Necrotizing ulcerative periodontitis, angular cheilitis, common, necrotizing stomatitis, and tuberculosis. So many mucosal manifestations will be there. Always have a look at mucosa. Next, forward. Yes. Okay. So autoimmune and idiopathic manifestations, phthosis, salivary gland disease, parotitis, oral hairy leukoplakia. So variety of conditions, HPV, oral HPV even. Candida we have discussed, oral Kaposi sarcoma and other malignancy can also. Next. Yes. Hair manifestations. See, HIV will not leave any part, any even, I mean, integument or whatever you call. So, hair manifestation, premature graying of hair, diffuse hair loss, pattern hair loss, alopecia areata, hypertrichosis of or long eyelashes. Even some drug, I'll show you probably, yes. One of the antiretroviral agent can cause hypertrichosis or long eyelashes. Nail manifestations, very common. Onychomycosis, yellow discoloration, melanotic band, black pigmentation due to zidovudine. So in short, skin, hair, nail, mucosa, all four are involved and we have a real great role to detect them, manage them in AIDS patients. Yes. So coming to herpes simplex virus, a very much important infection, right? It is said that HIV and TB is a double trouble. HIV and herpes is a double trouble because they are co-transmitter of each other. And even HIV-1 causing orolabial erosion and 2 causing genital lesions are much more common. There are frequent attacks of herpes and HSV infection accelerate HIV disease progression. There is twofold increase in risk of HIV acquisition in patient having genital herpes. So this herpes has got a great role. HIV herpes co-infection is to be picked up and treated. You will see giant herpetic erosions or perianal region, perigenital region, or even other extragenital site. Next. The good part is that, yes, chronic herpetic ulcers or of more than month duration is age defining ulcer. I have told you about giant ulcers, persistent, progressive, recurrent ulcer, right? The good part is that those herpetic erosions respond well to acyclovir or valcyclovir or famciclovir therapy. Most of the cases, of course, you have to give it for a longer period. That is the message, not a standard 1 week or 5 days therapy. Longer duration therapy or till healing occurs, you should give it. And whenever there is failure, in few cases, very small number of cases, you can give Foscarnet or Ganciclovir like that. Next. Yes. So you appreciate extensive herpes labialis in a small child, HIV positive. Next. Yes, you can see the lady having these herpetic erosions and the post-treatment. Next. Yes, these are our early cases of herpetic erosions where when people were not aware what it is, right? And ultimately you see the good response to antiretroviral therapy. So in short, this is a very common infection. Forward. Yes, herpes zoster. So we usually talk that herpes zoster is once in a lifetime phenomena and it occurs in middle-aged or elderly. But with HIV positive, uh, in children usually disseminated varicella or severe varicella occur, or even herpes zoster can occur in young children. And whenever you see young children with herpes zoster, do test him for immunosuppression and HIV, right? And usually here herpes zoster will be in younger population. It is recurring, hemorrhagic, disseminated, involving multiple dermatome. Herpes zoster ophthalmicus is also common. Again, I'll highlight that, or stress that regular antiretroviral, anti-herpetic therapy in terms of acyclovir or valcyclovir works. That is the good point. Next. Yes, few pictures. Herpes zoster with varicelliform eruptions, multidermatomal herpes zoster. Next. Yes, herpes zoster in children. You can see. You will not see this. This is the scar, of course. You will not see in immunologically competent child. Next. Yes, severe chickenpox in HIV positive children. So, uh, I mean, whenever you see such cases, you have to test for HIV. Mollusca, very much important, right? So we all are familiar with mollusca. So in HIV, lesions are numerous, they are extragenital, they are disfiguring, and in fact, extragenital molluscum contagiosum are a marker of HIV. The treatment is ART, and of course, cryotherapy, electrodesiccation, gentle curettage, or even in resistant cases, imiquimod can be used. Next, you will see genital and extragenital mollusca. Next, please. Yes, you appreciate that mollusca, you appreciate non-healing. There is even a genital ulcer, and you appreciate extragenital mollusca. Human papilloma virus. Again, this is an interesting interaction, HPV and HIV. So HPV can be extensive, numerous, resistant. HPV 16 and 18 are associated with carcinoma in situ of cervix, vagina, rectum, and high-grade dysplasia. And invasive cancer, cervical cancer, is aggressive in nature in AIDS case. You can treat it with a regular therapy, of course, and oral, HPV can be treated with even cidofovir solution. Now, fortunately, the vaccine is available, and we can give the vaccine to HIV positive patient, at least if the CD4 count is good. Presently, we start the treatment right after the positive test. So, if this is the good time to give HPV vaccine, particularly if the person is high risk, or even irrespective, you can give it. Next. Yes, so this is the HPV related giant, bots, and yes, this is Epstein-Barr virus related oral hairy leukoplakia. You can see corrugated appearance at the over the side of the tongue, and these particular cases are having very low CD4 count, and we have seen, many these type of cases having oral hairy leukoplakia. This is not needing any treatment. Start ART. Next. Yeah. Now this is a very much important part. Fortunately, now the present generation drug are causing relatively less adverse drug reaction, but we have seen lot of hypersensitivity due to antiretroviral drug. So as HIV altered immune status, pharmacologic factors are altered in HIV positive cases, and they are more prone to drug reaction as compared to normal non-HIV case, right? And it is postulated to be immune mediated, leading to involvement of recruitment of T cells in the skin. All NNRTI, most important being nevirapine, efavirenz, right? Then abacavir. These are among these NRTI and NNRTI group. These are the drugs which are known to cause hypersensitivity reaction. Now we have replaced nevirapine with efavirenz, but even efavirenz to some extent is known to cause hypersensitivity reaction. Abacavir is known to cause it. We have genetic markers or HLA markers available for even abacavir. Protease inhibitor can also cause hypersensitivity and other nail manifestations. I mean, pigmentary changes. Many things will be there. Interestingly or importantly, drug most commonly used for prophylaxis in HIV is cotrimoxazole. And cotrimoxazole, is very frequently cause maculopapular rash in HIV population as compared to non-HIV population. Next. Yes. Nevirapine induced grade 3 maculopapular rash. Even efavirenz can do the same. Drug hypersensitivity. Next. Forward. Yes. Pigmentary changes, nail pigmentation. This is zidovudine induced. You can appreciate a band over nail. This is Nevira. Yes, you can appreciate nail pigmentation over nail, knuckle, and a band over the nail as well. Next. Severe drug reaction or nevirapine induced SJ syndrome. We have seen this with even efavirenz. Right. Next. Yes. Stay-woodin induced lipoatrophy. Fortunately, this drug has now gone, but some of the protease inhibitor can also causes some changes like this. Next. Yes. Again, necrolysis in AIDS patient on nevirapine. Next. Yes. Another interesting point is HIV associated malignancy, right? So usually malignancies occur secondary to diminished immunosurveillance, I mean, and due to viral proliferation and virus infected tumor cells. It can occur HHV8, that is human herpes virus 8 can cause Kaposi sarcoma, Epstein virus, Barr virus can cause Hodgkin and non-Hodgkin type of lymphomas, and HPV cause cervical and other cancer, right? Other malignancy includes anal carcinoma, SCC, and testicular seminoma and other malignancy. So this is also interesting. The tendency for the early appearing tumors to be located at anatomic portals to the environment. That is anatomic portal. What are those anatomic portals? Skin, lung, larynx, oral cavity, penis, colorectal mucosa. All these anatomic portals, they have got high density of immunogenic cell, and thus high concentration of HIV at those sites, and this responsible for higher chances of transmission from those sites, particularly genital mucosa we have repeatedly discussed, and prepucial skin. Coming to Kaposi sarcoma. So it is caused by human herpes virus 8, and it is transmitted sexually, particularly by, anogenital sex or feco-oral route or the ejaculate rather than blood in HIV positive homosexual men. If you go back to year 1981, when few first cases of HIV were reported, they had Kaposi sarcoma and PCP in a gay population. So this is mainly a disease of in gay population in India. We have not seen many Kaposi sarcoma, but because still the major mode of transmission in India is heterosexual contact rather than homosexual contact. In Western countries and in USA, yes, it is homosexual contact are very common mode of. So what you see is a purple patches papule nodule which can ulcerate. It can be aggressive. It can occur in young people, and even it can be involve oral cavity and systems or lung like that. Good point is, I mean, the response, of course, the response to ART is unpredictable. So specific local or systemic treatment is often required. Next, yes, this is my patient of Kaposi sarcoma. Next, coming to other malignancy, right? HPV related malignancy. So, I mean, uh, very common vagina and mouth. There are 15 genital HPV are characterized as high risk genotype, particularly most of them cause cervical cancer. 16, 18, 13, 35, and so many other 15 HPV types are now being recognized or identified. Next. Yes. So this oncoprotein disrupt multicellular signaling pathways and facilitate viral replication, persistence, and it causes mutation in cellular genes. It accumulate and then leading to increased genomic instability and result in malignant transformation. Next. Cervical cancer. It is an AIDS defining illness. It is 5 times greater among female HIV/AIDS cases. It is associated with high frequency of multiple HPV genotype. There is higher prevalence and persistence of HPV in cervix, higher prevalence of cervical intraepithelial neoplasia, CIN, and SIL, high progression from low grade to high grade carcinoma, and greater likelihood even after therapy. So risk of SIL is greatest among women with, of course, low CD4 count. Next. There can be vaginal intraepithelial neoplasia, penile intraepithelial neoplasia as well. And HIV positive men have a twofold to threefold increase in penile cancer and high rates of penile intraepithelial neoplasia. So think when your patient come if with anogenital wart, he need follow up. Of course, now the good point is availability or accessibility of combination ART. Next. Yes, EBV associated malignancy, right? So EBV is the most common persistent virus infection in HIV cases, or even human being. 95% of world populations has an asymptomatic carrier state. So, I mean, we carry this virus without having any problem. But in immunocompetent person, there is, I mean, hardly any problem. But whenever there is immunosuppression, then the problem starts and malignancies occur. Next. Yes. So there is the risk is increased due to duration and degree of immunosuppression, induction of cytokines leading to B cell proliferation, opportunistic infection with oncogenic herpes viruses. See, herpes virus infection increase the risk of even lymphomas. So there are subtypes: classic Hodgkin's lymphoma and non-Hodgkin's lymphoma. Next. So, how to prevent HIV-related malignancy? So, first is combination antiretroviral therapy, screening of HPV-associated malignancies. Previously, Pap smear was used. Of course, now also Pap smear is important. Now, but now HPV DNA-based screening is available, and that is the best way. HPV DNA-based screening is, and looking for oncogenic HPV through this HPV DNA-based screening, whether there are oncogenic HPV or simple HPV, right? So this is a good way to pick up early malignancy or cases who are prone to HPV related malignancy. We have discussed that giving HPV vaccine at early stage of HIV infection immunogenicity in population having more than 200 CD4, but it is less if count is less than 200. So think of HPV vaccine whenever at first instance when you see HIV, particularly young and sexually active. Next. Yes. So malignancies continue to be a significant cause of morbidity and mortality. And it is, we have seen that caused by oncogenic viruses such as HHV8, EBV, HPV. impact of ART has been dramatic on Kaposi sarcoma, but AIDS-related lymphoma, HPV-associated squamous cell carcinoma, ART have little or no effect. Because the life expectancy of cases with HIV has increased, comorbidity such as cancer is also on rise, and further research is necessary. Forward. So I'm coming to the last part, that is preventive part and role of dermatology. Forward. Next slide. Yes. So HIV prevention, right? Yes. So coming to condom. So what is interesting is that condom is highly protective as far as HIV is concerned, or even, I mean, hepatitis B is concerned. This is a good point, but it is not highly effective for human papilloma virus infection and herpes type 2 virus infection. Next. Yes, circumcision. I have already highlighted that circumcision is to be promoted or as an additional HIV protection and STD protection strategy. Hardly 3% of global population people are India particularly, a very circumcision rate is very low in India. Next. Another important point is female condom. We all know that condom failure, or I mean reservation for condom use in male is there. So female condom promotion, though available, it is still now not used widely in, at least as far as our country is condom, I mean concerned, and it empowers female. It is very much important, or sex worker or female, or I mean like that. So I mean, it needs still to be promoted at a greater level. Next, vaginal microbicides. So vaginal microbicides, now tenofovir containing vaginal microbicides are in advanced stage, and but I don't think that they are still available in the market, or I mean approved for regular use. Next. So, so other strategy is test and treat policy. We have seen that treatment as prevention. See, this is a great decision of WHO, and this is forwarded by Government of India. You treat the patient, there will be zero viral load, there will be zero transmission of HIV. Of course, for that, early diagnosis, initiation of combination therapy, and most important is adherence counseling. Without adherence, the therapy, it is said that if adherence is less, the response, adherence, 95% adherence will give more than 95% protection. But if it goes below 90%, the protection is just 50%, right? Uh, Other things include post-exposure prophylaxis, particularly in occupational setup. We all still getting call that but doctor is pricked, and how to protect one. So nowadays, I mean therapy including this tenofovir, emtricitabine, and duolatavir is being recommended as 3-drug therapy. Pre and post sexual exposure prophylaxis. These are for special situation. Uh, Both can be, I mean, in a limited scenario, it is to be promoted. Pre and post sexual exposure prophylaxis. So, what is our dream? From manageability to curability and highly effective vaccine. So, these are our dreams. In hope in coming 5 years, at least HIV become curable rather than manageable, and we will have vaccine. This is my hope. Next. So our time or time of dermatologist is not over. Dermatologists have still a crucial role to play in management of HIV and AIDS. I think with this, from my side, thank you all. You gave me your time, the most thoughtful gift of all. Thank you all. If time permit, I am open to question, or I am always available to interact through either WhatsApp or email. Thank you again.
Thank you, Mafatia sir, for your excellent presentation. I now invite our second speaker, Dr. G. Venkatramana sir, retired professor and HOD, Usmania Medical College. He has many publications to his credit, and his academic career he has presented at international, national, and state forums on sexology, STD, and HIV and AIDS. Sir also received many awards and honors. To his credit, Golden Lamp Award in Indian sexology field, and an outstanding service award in sexology, and he's also an associate editor for Journal of Sex and Marital Therapy. Dr. Venkatramana sir is a legend in the field of sexology and HIV and AIDS. Over to sir. Sir, we welcome you, sir.
Thank you, Ma Kavita. Thank you. Very kind of you for your kind introduction. My dear Iadvlites, good evening to you all. And at the outset, let me thank Telangana Iadvl, particularly DBN Murthy, Bhumesh, Kavita, and Janardhan and their team for inviting me here to speak on this pleasant evening and the beginning of New Year 2021. Now we heard our past president, national president Yogesh Marfatia, HIV and skin. Now let us see about STDs and HIV. My friends, we all know that in the entire universe, every living organism, right from unicellular amoeba to highly evolved, way thinking animals, everybody is bestowed with a basic instinct called sexual union. This basic instinct is expressed for procreational purposes in all living organisms except we human beings. We human beings are expressing this for recreational purposes, the priority. Procreation has taken second place. In spite of recreation, we are 140 crore population, second to China. We are going to beat China, blue and black, take the first position by 2025. When any person who does sexual experimentation, two types of problems can crop up, or two types of patients can come to you and to me. At one side of the coin, patient may come to you with sexual infections. At other side of the coin, the patient may come with sexual dysfunctions. Now today we concentrate on the sexual infections. These sexual infections are previously called venereal diseases. Now they are called sexually transmitted diseases or infections. They are nothing but a group of infectious diseases predominantly transmitted from person to person through sexual intercourse. Though other ways of transmission are there. The big mystery here is how these STDs have entered into the human kingdom. It's like a chicken and egg story. But the history shows, anthropological surveys and genetic surveys shows that all these STDs have started peeped into the human kingdom through animals, sheep, cattle. And they started as only dermatological conditions on the skin of the feet and hand, then entered into the oral cavity as a mouth, then entered the genital cavity and started STD cycle, that is sexual route. So there are two theories in the world called pre-Columbian theory or old world theory, or Columbian theory and new world theory, which speaks about how the transmission has occurred. Till World War II, there were only 5 diseases. Those are called first generation STDs or venereal diseases, namely syphilis, gonorrhea, chancroid, LGV, and granuloma inguinale. The reports of the Second World War clearly shows that 3.2 million Americans have been suffered with syphilis. First 2 years of World War, Japanese killed 36,000 Americans, whereas syphilis alone killed 33,000 Americans. So it's as good as World War killing. Syphilis has killed so many people during the Second World War area. Then after the Second World War, sexual revolution has started in 60s. Baby boomers, hippie liberation came into existence, and oral contraceptives have came into the doctor's armamentarium. As a result, the liberation of fear of pregnancy has gone, and a female entered into the workforce, and air travel has started. As a result, all this plus availability of antibiotics, penicillin came into the use, tetracyclines came into the use. As a result of all these things, many more STDs have came into the human existence, namely non-gonococcal arthritis, chlamydial genital infections, herpes, genital warts, trichomoniasis, pedicellus pubis, scabies, molluscum contagiosum came into existence. So this put together, second generation has come. After this, in 70s, gay and bisexual revolution has started. As a result of this, anal pathogens have entered into the genitalia, sexual route. As a result, third generation came into existence, which consists of hepatitis B, hepatitis A, salmonella, shigella, giardiasis, amoebiasis, gonococcal proctitis, gonococcal pharyngitis, anal herpes, anal warts, chlamydia, and gay bowel syndrome. So these are the third generation STDs that came into doctor's armamentarium, or rather person-to-person transmission. Then of late, in 1980s, social behavior revolution has came. Society has loosened the moral values. Society started seeing as a Janedo attitude, and people's moral values have come down, and sexual liberation has started. As a result, more openness has come into the society. More mingling, free sex has been became a norm in many societies. As a result of this, new diseases entered into the human kingdom. One among them is HIV, a fatal STD. Apart from HIV, HTLV1 and 2, cytomegalovirus, Hep C, Mycoplasma, Mobilincus, human herpes virus type 8 causative of Kaposi sarcoma. Just now, Marfatia spoke about it. So, my friends, put together today, more than 30 bacterial, viral, parasitic pathogens are transmittable sexually from person to person. So, today we have more than 30 STIs. All these STIs predominantly transmittable from person to person is sexual intercourse. 90% today, all these infections are transmitted through sexual intercourse. Remaining 10%, either transfusion of infected blood and blood products, or sharing of injection and needles, or mother having infections, a transmission to the next generation called vertical transmission, or sharing of tattoo needles. We healthcare providers like nurses, paramedical staff, lab technicians, and doctors, we get some accidental injuries and accidental spills into the eye, needle stick injuries. So these are all the various documented routes through which these pathogens can be transmitted from person to person. So predominantly it is a sexual mode of transmission, followed by infected blood or blood transfusion, followed by sharing of IV drug abuse, sharing of needles, then infected mother becoming pregnant and for transmission to the offspring, then followed by skin to skin contact, accidental cuts and needles for healthcare providers. So these are all the documented routes through which these pathogens can be transmitted. Because of this, all these STDs are seen as a marker for high risk behavior, and they are marker for chances of getting high chances of getting HIV infection. My friends, each year there are estimated about 360 million new infections, particularly gonorrhea, chlamydia, syphilis, and trichomoniasis are increasing year by year. More than 1 million sexually transmitted infections acquired every year worldwide, every day worldwide. So 1 million means almost it turns out to be 12 cases per second. In the world, for every second, 12 cases are coming up with STI infections. You can see the rapidity. If you look at it in Indian scenario, 35 to 36 million episodes of STI are occurring in India annually, boiling down to for every second, one case is occurring in India. For every second, one case of STD is manifesting in India. This is a very, very, I can say, high prevalence. Women and children are bearing the brunt for this because of these STDs are notorious for asymptomatism. Majority around to the tune of 50%, all these STDs, they won't manifest clinically. There won't be any symptom. That's why the person may be woman or a man or a boy or a girl or a student or they don't know that they are harboring these organisms in their genitalia or in their body. Women and children are more burnt because of their complications and sequelae of it. So they are taking more burnt of it. And at the same time, if timely intervention is not there, all these STDs are precursors for preventable infertility. If timely treatment is not there, infertility, they are going to become infertile. They are prone for ectopic pregnancies. They are prone for malignancies, cervical malignancies, neonatal infections, neonatal deaths. So a lot of morbidity and mortality. All these more than 30 infections are caused by either bacterial or viral or fungal or protozoal and ectoparasites. When I was a student, all these diseases are called venereal diseases. When I was postgraduate, the terminology changed to sexually transmitted diseases. When I was a medical officer in PSC, the terminology changed to sexually transmittable diseases. Then came STI to include asymptomatic infections. Then came genital infections in the West, reproductive tract infections. All these infections are rapidly progressing, transmitting from person to person because of the demographic factors, social factors, behavioral factors, and medical factors. I'm not going in detail about this, but to say in short, that India is having 2.4% of the land area of the world, holding 17.5% of the world population. That means population overload, as a result of which population migration will be there frequently from villages to districts to cities for the case of better education, better employment purpose, for better living purposes. As a result, we are going to have more demographic factors will play a role in the transmission of infections. Then social and behavioral factors, lot of factors will play a role. Promiscuity, fear of parents, fear of God, fear of pregnancy. Thanks, there a lot of antibiotics, OCP is, condom is there, fear of parents. When we are coming all away from our parents, that is also gone. We are happy home environment gone, congenital work. So many factors are playing a role. In order to control this, even before independence, our British government has launched a program called National STD Control Program, launched way back in 1946. In this program, lot of STD clinics are opened across India. After HIV, lot of STD clinics in the name of Suraksha clinics came into existence. So once this NACO is formed, National AIDS Control Organization is formed, this STD control program is merged with the National AIDS Control Program from 1992 onwards. Today, in the country, in India, we have 1,160 STA clinics are there, government sector and private sector. These are called Suraksha clinics. In Telangana, in our state, we have 36 Suraksha clinics, dispersing, not only identifying the cases, giving the health education, not only doing the partner treatment, giving condom promotion. We are treating through this color-coded kits. These are all available, supplied by the NACO. We are giving this, along with this distribution of this, we are treating them, educating them, giving counseling them, and giving partners treatment also. Laboratory support for all these are available, and we are training a lot of medical officer training and lab training is there. And we have established 5 centers, one including Hyderabad. We have center to train the healthcare providers in this STD matters. And coming this fatal STD called HIV infection, in 1980, CDC, Centers for Disease Atlanta, got lot of demand for request for pentamidine, a drug that is used for treatment of pneumocystis carinii pneumonia. When so much demand has come, they constituted a committee called Epidemiological Intelligence Service Committee, which entered into the entered into the existence and went there and saw why so much demand. So they met the doctors, they met the patients, and they could see that all these patients are suffering with immunodeficiency because of their homosexual activity on that day when they observed. So they could coin a term called acquired immunodeficiency syndrome way back from 1981 onwards. So it is the first 1981 Gottlob et al. Who described and named it as AIDS. But no causative agent is known why they got that acquired immune deficiency. 2 years after that, in 1983, Luc Montagnier from Pasteur Institute, Paris, and 6 months after that, 1984, Robert Gallo from American Cancer Institute, they declared to the world that we have isolated the causative agent. Luc Montagnier isolated the agent from lymph node of a patient. That's why he named it as LAV, lymphadenopathy associated virus. Whereas Robert Gallo isolated from the blood of a patient, he called it as HTLV3 because HTLV1 and 2 are there already in the human kingdom. Both are same viruses called by two different names because they have isolated from different areas of the human body. In order to avoid confusion, from 1985 onwards, we are calling universally this virus as HIV. Coming to the India, in order to say that we don't have HIV in our country, in 1985, when we are conducting Asian Games in Delhi, we have constituted a committee to say that HIV not entered India. But our surprise, to entire nation surprise, 6 commercial sexual workers from Chennai are reported. In those days, I am also involved in this, and we went to the jails, we went to the hotel workers, we collected samples, we sent those samples. Only 2 centers were there in those days. One is Vellore and one is Mumbai. We sent the samples there, and to our surprise, 6 commercial sexual workers came from Chennai. That is a blow to our belief that we are very, very pious. HIV won't enter India. But that was a clear indication HIV has entered India. Now, since then, series of events have occurred. 1986, first case of HIV detected in Chennai. 1990, HIV/AIDS cell started in the Ministry of Health and Family Welfare, Delhi. 1992, first National AIDS Control Program was launched. Subsequently, now we have crossed even the 4th NACP also. This is a beautiful virus which even our Marfatia shown you. So this virus is having 72 nerves, as I already shown you. For the junior people, for PGs it's concerned, it is a virus, a RNA virus having a single stranded genetic material, and it is equipped with a special weapon called reverse transcriptase. These are the 3 things. At the same time, this virus has jumped into the human kingdom from chimpanzees and Sutabe monkeys, because this virus is of 2 types, HIV-1 and HIV-2. HIV-1 has jumped from chimpanzees, HIV-2 has jumped from Sutabe monkeys. There are a lot of serotypes are there. In India, it is subtype C, and subtype subvariants are very common. This is HIV-2. All these HIV virus we are the only susceptible human beings are the only susceptible organisms in the entire universe. No other organism, no other living organism is susceptible. It is only those monkeys and this man. O bandar, ye banda. That man and this monkey. These are the only 2 living organisms that are susceptible for this. Since we are having receptors for this, we are susceptible. So once the virus enters the body, through that 72 knobs on the surface, they will go and stuck to the receptor and start the pathogenesis. They will enter the human cell and start the pathogenesis from the special weapon called reverse transcriptase. That RNA becomes a DNA, and DNA is integrated into the nucleus. From there, multiplication and release of daughter variants will come. The epidemiologists thought when this virus would have been entered into the human kingdom, and they could see that in 1920s, this would have been entered from the Congo, Republican Congo, that is now we call Kinshasa in those days in the African country, would have entered from there into the human kingdom. And now it has taken the epidemic proportion, leading to spreading to all continents, becoming a pandemic. My friends, even HIV also is transmitted as sexual route only, predominantly sexual route, blood and blood transmission, mother to child transmission, parental drug transmission, accident cut and needle stick injuries. So again, sexual, mother to child, infected transmission of blood and blood products, sharing of needles. So this clearly shows STDs and HIV are all transmittable through same risk factors, same routes only. As I told in the beginning of my talk, 90% is through sexual. In order to know how many HIV cases are there in the world, or in India, or in our state, and every state, so every year on the 1st December, we are observing as World AIDS Day. We dermatologists are playing a very important key role in HIV and STDs. So we are observing not only leprosy day, psoriasis day, and vitiligo day, we are observing World AIDS Day also. So this World AIDS Day, we're observing from 1988 onwards with a theme of communication. Now we have entered in 2020, we observed as a global solidarity and shared responsibility. So we are all familiar with this AIDS educational material from Redmond Express and this. And free calls, only call centers we can have. One is there in the South, entire South India, Hyderabad is hosting a free call center here. So this is the Solidarity 2020. We observed the World AIDS Day. So these are all the photographs of which when I was working in Usmania and Gandhi, I'm showing those photographs where we conducted a lot of awareness programs on these HIV days. So these are all the things we're just sharing for you. So these are all the, this is from Gandhi, this is from Usmania, this is also from Usmania who shared. So every year on the 1st December, we are observing this. Today, our prevalence rate is approximately 2.1 million cases of HIV are there in India. Approximately 0.2 million cases died. 1.8 million means that 1,80,000 cases are on ART now. We have in India, we have more than 8,68,000 female sexual workers, more than 4,27,000 male sexual workers, and we don't have any figures of transgenders. We have IV drug abuse people of 1,77,000 and truckers of more than 2 million cases spreading from Kanyakumari to Kashmir, and they will be going and spreading the infections and getting the infections. The highest state prevalence states is the Nagaland because of the IV, predominant IV drug abuse transmission, followed by Mizoram, Manipur, Gujarat, Chhattisgarh. We Telangana, we are in the 6th position where our prevalence rate is 0.39%. So all our states among these, Hyderabad and then Karimnagar, Warangal are taking the lead. We have 22 ARC centers in Telangana state. And our twin cities, Usmania, Hyderabad, and Secunderabad are having 5 centers here, catering to the needs of the people. As I told you, once the virus enters the body, since we are having receptors, we are susceptible for this because of the 72 knobs that go stuck to the receptors. Then co-receptors will play an important role. That's why all people, all dermatologists or HIV physicians who are treating might have observed that some patients are not getting HIV infection even after repeated exposure to repeated risk taking. This is because they are having defective in the core receptors. Lucky people. So some people are there where they won't get HIV infection because of the defects in the genetic defects and the core receptor sites, CCR5 and CXCR4 core receptor sites. I have seen more than 24 people in my 30 years of experience as HIV specialist, where husband positive, wife negative, girlfriend positive, boyfriend negative, boyfriend positive, girl negative, like this, plenty are there. This is because prevalence rate of 1% of white population, homozygous deletion, heterozygous deletion is 10 to 15% of population are there. So once the virus enters the human body, around 2 to 3 weeks, the person will develop seroconversive illness, acute flu-like syndrome. This even Marfati has discussed. As a result of this high viremia will be there, and CD4 count fall will be there. And this subsides by its own, and the patient's immune system try to recoup. And because of the increased viremia, CD4 cells starts falling. When it starts falling below 500, lot of opportunity infections will come. And once it starts falling below 200, it is called AIDS. Up to 200, it is called only HIV infection. And once it falls below 200, lot of severe OIs will come, infections will come, and ultimately we are going to lose the patient if not treated. That's how the natural history goes. So some people, they will rapidly go to death because of weak T cell lymphocytes. Because of the CD8 T cell lymphocytes, they will go to rapidly progress to eighth stage. Some people who have strong CTL reaction, they will slowly progress. Majority, 90% will be moderate CTLs. They will take around 4 to 7 years to reach this. So these are the three patterns we noticed. 90% will fall in the moderate group, 5% strong CL. Even today, they are not at all going to progressing to 8th stage. Weak CL, certain people, within 2 to 3 years, they will go to 8th stage and they will succumb to death. The progression of HIV infection from asymptomatic stage to 8th stage depends upon the viral fitness, co-receptor usage, mutations, latency, and host factors will play a role. HLA types like B25, B8, B27, B57 known to associated with slow disease progression. This is very important. That's why some people with HLA B27 and B57, they're lucky people. Vitamin A deficiency, rapid progression. Tuberculosis, rapid progression. So this virus can be prevented through therapeutic interventions, behavioral interventions, structural interventions. Structural interventions like comprehensive sex education, universal condom usage availability, expanded syringe access, and health coverage and stable housing, eliminating the disparities and stigma and decreased properties. Whereas therapeutic interventions through usage of treatment. The first drug that is approved for treating this is in 1987, zidovudine is the first drug. Rapidly, today we are having very good number of drugs are available. Today, we have more than 30 drugs to treat this condition. Previously, way back in 1990s, where we used to treat with 1 or 2 drugs only. So monotherapy or dual therapy in those days. Later, guidelines came to treat with a minimum 3 drugs. So he is the one, he's called a champion of HIV drug, cocktail therapy. And Time magazine has given him as a Man of the Year award in 1996. He is a David Ho. So then combination of drugs came, zidovudine, lamivudine, nevirapine, savidine, lamivudine, nevirapine, like this. Plenty of combinations came. Then many more drugs came into the existence and fixed drug combinations. A lot of tests came into doctor's armamentarium and lot of guidelines went to treat when the CD4 cell went to treat. All these things came into, we started treating them. Now today, because of the availability of good drugs, lot of combination of these drugs are there. As a result of which patients used to take humpty number of drugs, 20 to 25 tablets a day became to 2 to 3. Now today it is only one tablet is sufficient, which contains 3 medicines, and that will tackle the entire HIV infection. So they have combined all that medicines into one tablet because of synergism, reduces toxicity, and that will prevent the resistance. That is the attitude, beauty of the combination. And all these drugs that are available can be utilized for the clinical case management, PPTCT, that is prevention of pregnancy to child transmission, or PEP, post-exposure prophylaxis, or PrEP, pre-exposure prophylaxis, and now of late we are using occasionally for non-occupation, that is PEP-say, post-exposure prophylaxis of sexual exposure. So these are all the various areas where we can use this. So one is for accidental cuts and needles for we healthcare providers, for prevention of pregnancy and child transmission. There's a lot of research is there, a lot of evidence is there that if you treat effectively the pregnant woman, we can reduce it to 0.2%, and it can be made zero by using prophylaxis also. So this is how the four-pronged approach of the WHO goes: primary prevention of HIV, preventing the unintended pregnancies, preventing the MTCT, then giving a good care and support. And this Cuba is the first country in the world that had made the PPTCT to zero. Cuba, a small country thriving on the agriculture, could foresee the future of the country and could implement the PPTCT very effectively and could bring it to zero. Thailand is the next country that is thriving more on the commercial sex and tourism. That country could achieve it zero. Where are we now? Why can't we achieve? So, well, every healthcare provider now has to rise to this occasion and see that we too will achieve, we too will join the list. Now, WHO has came up with a novel idea of test and treat. 2016, and we Indians have taken that test and treat on May 4th, 2017. Our then Honorable Prime Minister, our Modi ji, has given a statement saying that we are launching test and treat as per WHO. Of late, 2014, UN adjust to fast track approach to control this epidemic. 90. What is this 90? Not 2020, it is 90. This 90 is 90% of people living with HIV should know their HIV status. Among these 90 people, 90% should be their positive status on treatment. In this 90% people who are on treatment should be on effective treatment with suppressed viral loads. So 90% people should know their status. Among this, 90% should be on treatment. Among this, 90% should have suppressed viral loads. This is the target. If we achieve this, this epidemic will be closed. We can end this epidemic if all citizens are tested regularly, all treatment started with treatment, and adherence to and monitoring the treatment. This is very, very essential. So India commits to end this epidemic by 2030 in a high-level meeting during the General Assembly of the UN. We are the signatories and we promise that we are going to end it by 2030. So the fast track targets given by 2020, our new infection should be fewer than 5,000, 5 lakhs, new related deaths should be reduced by 5 lakhs by 2020 to eliminate HIV-related stigma and discrimination by 2020. Of late, recently, I was there in this conference in 2018 in Amsterdam, where there's a CROI meeting. They came up with saying that another boon has come to the HIV physicians and to the HIV patients. If these patients are on suppressive ART, if their viral loads are below detection, their risk is zero for transmission. So this is a boon that HIV couples can have healthy, uninfected children. That is a boon that came in 2008. Undetectable is equal to untransmittable. So as a result, now healthy children can be given and assured for the people who are waiting for HIV couples who are waiting for children. Science has validated that undetectable is untransmittable. At the same time, my friends, there are success stories, two success stories in the HIV history. One in 2007, Mr. Timothy Ray Brown. He is popularly called as a Berlin patient because he is an irregular patient in those days. Anthony Fauci is now heading the American Association of this one CDC, and he used to say that he's an irregular patient. and he developed the malignancy. For that, the cancer therapists have planned bone marrow stem cell transplantation. And fortunately, we don't know in those days co-receptor concept and its role. Fortunately, the donor was CCR5 deficient person. So that bone marrow has been transplanted to him. And after that, when HIV doctors tested, and his HIV has disappeared. That made a surprise to the entire world. And that is, then they started investigating how it happened. Then it came out that donor was CCR5 deficient. So that is the first success story where the person is become now free of HIV because of the taking bone marrow, CCR5 deficient bone marrow. The second success story recently occurred in 2019 is called London patient, and he developed Hodgkin's lymphoma. He is selectively taken CCR5 deficient, delta deficiency bone marrow transplant, and he is now happily surviving and free of HIV. These are the two success stories. My friends, I am also coming to the end. Now, the therapeutic intervention is PEP, TAP, that is treatment as a prevention. This is the new TAP. If we are able to treat effectively these patients, making their viral loads suppressible, that can act as a prevention also. It won't transmit infection to others. Treatment as prevention, new concept. So adherence, good effective treatment, see that their viral loads will be under detection. That is very, very important. Then behavioral interventions are abstinence, mutual monogamy, safer sex by using condoms, and reporting to doctors at the earliest. Test and treat. Laboratory investigations for all STDs and HIV. Blood tests will take an important step. Then blood tests, swabs from the penis and urethra, swabs from the vagina, cervix and urethra, swabs from the oral cavity and anal cavity, urine examination, all will play a role. At the same time, we should not forget, we the treating physicians, we should not forget, treating the index case alone is not sufficient for HIV and STDs. We have to treat the partners also. From where he got or she got infection, to whom he or she has given the infection. From where he or she got infection is called primary contact. To whom he or she has given the infection is called secondary contacts. This primary contacts and secondary contacts has to be treated. Then only the treatment is complete. Then only we can stop these epidemics. In those days, when I was a postgraduate, we used to give referral chits to the index patients. They have to go and give the chit to the partners. Partners will come taking the chit. Then we can understand, though we'll be referring the register. And so the index case has this problem. So this is the contact of the index case we used to evaluate and treat. Followed by cluster testing came. Now we are using this concept of expedited partner therapy, where we are giving the full course of treatment. What we have given to the index case, we are giving the treatment to the index case and asking to give it to the partner so that we can reduce the infection even without coming to the hospital. So my friends, the link between STDs and HIV is epidemiological synergy. Both are interlinked. Similar behaviors put patients at risk for both STDs and HIV. Sex with multiple partners, IV drug abuse transmission, IV needle contamination, pregnant mother to child, both things will be same for STDs and HIV. Prevention of risk factors and control of behaviors can reduce both problems. Since risk factors are same for both, prevention of risk factors will hold good for both. Any activity that decreases STD in the community will also decrease HIV, because STDs will increase the chance of acquiring HIV infections, ulcerative and discharges. All these STDs that manifest in the form of ulcers, discharges and growths. Ulcers and discharges, they'll make the persons to acquire infections 5 to 10 times more easily. At the same time, early detection and identification treatment of STDs will reduce the HIV transmission also. That's why STDs play a very pivotal role in the HIV epidemic. So this is how ulcerative conditions will acquire the infection. If the patient is already HIV positive patient developing ulcers, he is more risk for others. He will be transmitting the infection more easily. People with ulcerative and discharge lesions, 5 to 10 times more chances of getting infection or more chances for transmitting the infections also. So that is very important thing. At the same time, people who suffering with HIV, if they get STDs, these STDs will manifest atypically. There won't be any typical manifestations. So, for example, to say herpes typically manifests as a grouped vesicular lesions, then rupture producing grouped erosions. Whereas in HIV patients, they will manifest as a single erosion. Perianal ulcers, all ATP are exaggerated presentation, which Marfati has shown one slide also. So such is the clinical presentation in the presence of background of HIV. How to prevent these STDs and HIV? The standard, gold standard is no sex till marriage. That should be the gold standard. Or have sex with in marriage only with wife, monogamy. After marriage, sex with mutually faithful monogamous partners. This is the second best. If these two are not possible, then always use condoms in every occasion, correctly, consistently. If we use condoms correctly, consistently, we can stop almost to the extent of 98% of HIV infections, but 50 to 90% of STD. Because condom will be only covering to certain part of the genitalia. Rest of the part is prone for STDs. But it prevents totally HIV infection, 98%. So once we condomize, we can prevent the infections. So there should be a slogan. It should go for every youth of India, youth of the world, no glove, no love. So that should be the moment. If all these fail, should not hesitate. Stigma, discrimination should not come. You should report early to the doctor so that we can treat early, test and treat immediately, so that we can prevent the disabilities, we can prevent the morbidity, mortalities. So that's how we treating physicians should develop the attitude of diagnosing the index case, treating the case appropriately, giving health education and counseling, and treating the partners and counseling the partners, promoting the condoms, and regular follow-ups. With this, my friends, I am closing my talk, and thank you for your patient listening. Thank you very much.
Thank you so much, sir. It was indeed a very great presentation, as usual, sir. Thank you so much
Thank
once
you.
again. I now welcome Dr. K. Bhumesh, sir, Associate Professor of DVL Gandhi Medical College, who is the Honorable General Secretary of TSIDVL. To his credit, he has many publications and also presented papers at national and international conferences, received many awards and honors also. And his main areas of interest is in pediatric dermatology, mostly on allergic and infectious dermatosis. Over to Bhumesh, sir.
Bhumesh, unmute yourself.
Yeah, can you hear me now?
Yes, go ahead.
Yeah. Thank you, Dr. Kavita, for your kind words. So now I am in midway between the quiz and my talk. So the most of the younger people, they're waiting for the quiz. So almost excellent, after excellent two talks on then there's something related to the community awareness. This is a theme Iadvl fight the topical steroid misuse. Why this misuse? Because the steroids will have a bleaching effect. So that's why directly that's used in the fairness and beauty creams. But this is not correct. So if you want beauty, you do regular physical activity and healthy diet. That is main focus. We healthcare providers, we try to sensitize ourselves, then we'll try to sensitize the patient. And it has anti-inflammatory effect. So that's why even infective conditions like fungal infections, because of inflammation, if you use, the lesion will subside. but that is not correct. Even combination creams, if you have any difficulty, particularly in RMPs, PMPs, directly they will use a combination cream. But please discourage the usage of combination creams. If you know the diagnosis, use it. If you don't know, take the second opinion. And because unfortunately the market is full of combination creams, so this has to be discouraged. And the double and triple combination creams are available, and you will see the inflammation, all those things will disappear, fast relief, and at the same time fast relapse. The cutaneous immune system, which will suppress this over a period of 4 weeks if you use continuously topical steroids. And again, except in India, all over the world, this over-the-counter, the topical steroids are not available. Only it is available in India. So they'll go to the medical shops and purchase. But our humble request, we'll try to sensitize, at least each person should sensitize another 10 people to sensitize more and more by visiting the doctor. If you have any skin problem, please visit skin doctors, skin specialists, wherever you are. And sometimes misdiagnosis, particularly in the babies, if you think of any itchy conditions, they think of atopic dermatitis. To differentiate this, atopic dermatitis bilateral. If you see this unilateral, use potent topical steroids. After 2 weeks of treatment with meconazole cream, so just hypopigmentation. So accurate diagnosis is very, very important, especially in the pediatric age group. And all lesions in the diaper area is not diaper dermatitis. Maybe a diaper dermatitis, a primary irritant contact dermatitis. But if you see the diagnosis of diaper dermatitis, use topical steroids, it has been modified. See the bar. So always use, examine the baby. So just if you think any itching condition is in the diaper in the inside, just don't assume that it's a diaper dermatitis. And you see this combination creams and the rituals, these all will cause these problems, combination creams and topical modified tinea, and that gives rise to the chronicity and recalcitrant dermatophytosis. Then if you see directly, they'll go to the over the counter potent topical steroids. You could see some lesion immediately subside. If they stop, you could see the inflammation of this. But our duty is, when the patient is symptomatic, you explain the natural history of that fungal infection. Because when the patient is symptomatic, they will follow the instructions of the doctor. Otherwise, if the patient is asymptomatic, they won't follow the instructions of the doctor. How beautiful you are, how handsome you are. So that's why you try to explain the natural history of particular conditions when it is symptomatic. You could see after 7 days all the lesions. So when you see that, you abruptly advise the patient or caregiver, stop topical steroids. You explain that once I am stopping, but over a period of 1 week, you will get some lesions. But if you continue, all lesions will subside. You could see the whole family as directly they went into the medical shop and used the potent topical steroids over a period of 1 year. So to resolve it has taken almost more than 6 months. Why they are considered unsafe? Because it can cause topical steroid damage phase or modified tinea. So these are all manifestations. I won't go in detail. What is the magnitude of the problem? Even our Iadvl has done the studies. So even most of them, they are contain these potent topical steroids in the beauty creams. How to manage this ill effect? Stop misuse immediately. So you advise them, stop them, and consult qualified dermatologists wherever they are. Because if you use prolonged, that can convert irreversible conditions. How to address this nationwide problem? Because the target groups, so public health awareness, what we are doing in all our derma days, we are doing with this team Iadvl, and college students, nursing staff. The college students and teenage people, mainly teenage people, neither they are children nor they are adults. So they will do experiments. Directly they will go to the medical shop and they will use they will go to the direct medical shops and use the medicines by experimenting. So that's why they are the target groups. You try to sensitize more and more in different platforms. So that's why the team Iadvl of this the 10 letters is working with all 10 committees headed with the national EC almost since 2019. It is working under the leadership of Dr. PNR, and next it has continued with Dr. Kiran Gadse. Now also it is working for healthy skin and healthy body and healthy skin. So unless until the skin is healthy, no. So ఆరోగ్యమైన చర్మమే ఆరోగ్యమైన దేశము, ఆరోగ్యమైన దేశమే ఆరోగ్యమైన దేహము, ఆరోగ్యమైన దేహమే ఆరోగ్యమైన దేశం. So we, the skin specialists, try to sensitize more and more the importance of the skin health has to be initiated from the pediatric age group, because if you neglect first 18 years, almost 80 to 90% of the skin damage which will take place. It is our duty to sensitize by ourselves by the importance of the maintenance of the skin health, subsequently body health and the nation health. So that's why we all are working that. So especially for a younger generation, try to sensitize at least one person should take the responsibility of to sensitize another 10 people, and let the 10 people, another 10 people to sensitize another 10 people. If the chain goes and it will reach us to the community level, then the skin health and body health and nation health will, the purpose will be solved. So that's why please spread the message of avoidance of topical steroid misuse either alone or in a combination to all concerned. Unless until we sensitize, we cannot sensitize others, these patients. So with the slogans, the topical steroids are the doctor prescribed drugs, please, and prefer non-combination creams. Say big no to self-topical corticosteroids. You explain the sustain beauty, sustain skin health by healthy diet, not by topical steroid or fairness creams. So the sustained beauty by balanced diet, not by fairness creams. The topical steroids are not the solution for the treatment of acne or dermatophytic infections. So say no to self-topical steroid use. So what more can be done? So legislation or stronger implementation of existing laws. So even the higher levels of Iadvl has given representation to the different authorities, but it has to go in further. A sincere request, please spread the message of avoidance of topical steroid misuse or abuse to all concerned. So we don't grow when things are easy, we grow when we face challenges. Unless until we face challenges, we cannot grow. So help spread the message of stop the topical steroid misuse to maintain good skin health for healthy skin and healthy child and healthy body. So with this, so thank you very much for your kind listening. So over to Dr. Kavita.
Thank you, sir, for your presentation. And now I welcome the most awaited quiz, Dr. Satyashri, who is an associate professor from Gandhi Medical College. Over to Dr. Satyashri, ma'am.
Yeah, can you hear me, Kavita?
Yeah, we can hear.
Yeah.
Yeah, quiz master, Dr. Satyashri, the quiz, the instructions.
Yeah. Share the screen. Chiranjeevi.
Chiranjeevi, share the screen. So these all questions, the questions will be taken from the previous speakers only. In any all Dermanar, the questions.
Those two talks, if you follow PGs.
Instruction share cheyalana?
Yeah, instruction share.
Chiranjeevi, are you sharing it?
And after.
Yeah. So postgraduate quiz instructions, 10 MCQs, you have to answer all. Mark one correct answer only. So duration is just 5 minutes. First 5 toppers will be selected and Quizmaster's decision is final. Don't refresh or close the browser. Thank you. Yeah, start.
Chiranjeevi, questions should be visible for everybody. Yeah. But they can answer, PGs can answer, but the questions should be visible for everybody.
Yes, sir. Questions is visible for all LM members.
Yeah.
For PG people, they can answer the questions.
Even Zoom, can we see or only we cannot see?
No, sir. I mean, we are starting the quiz now.
Okay.
Okay, sir. Just give us a second.
Sir, it has been started.
Okay. Sir, after 5 minutes, we'll show the questions with answers, sir. For
Yeah,
each of
yeah.
the series.
Yeah.
Okay.
Yeah.
So I keep that answers thing ready, ma'am.
After answer sheet,
Sure,
there is
sir.
a question answers. Then the results will be declared at the end. Then followed
Okay,
by vote of thanks.
Sure, sir. Sure.
Meanwhile, any questions have been posed?
Yeah, questions was posted in the group, sir, already. So,
No, not for quiz questions.
No,
Yeah,
those are
in
also
the-
it is posted.
In the chat, there are 5 questions, sir. You can see.
So we can answer those questions, no?
No, after this
After quiz.
answer sheet, Dr. Sachasri will read the answer sheet, then the question answers, then the declaration of results, then the vote of thanks. Let them answer. First program, sir, good success. Initially, it was started with a 20, then it has crossed 200.
200.
Almost,
Very good.
first,
Very good. It has to cross 500 in subsequent seminars, Zooms.
Yeah,
Easy.
first program, actually, I thought of 20 and 50 and cross.
Excellent. 200 is no another vibrant person of Telangana.
No, it is effort of everybody. So all the speakers in the IT team, even IT 10 people, they are working behind us.
Yes.
So
That's a very good support for us. Hetero is a very good support for us.
Even midnight also I used to disturb them. So continuously.
చిరంజీవిని తలుచుకుంటుంటాడు
నన్ను తిట్టుకోకుండా దాని చిరంజీవి.
తలుచుకుంటాడు.
But our effort has worked out, sir. So almost 225 is good number. First.
Yeah. మొన్న ఈ సెక్స్కాన్ చేసినప్పుడు అన్నాడు చిరంజీవి, ఇంకా ఇప్పుడు మాతో 5 days మొత్తం టెస్ట్ మ్యాచ్ ఆడిపిస్తాడు సార్ భూమేష్ మాతో అని.
అంటే సగం లా వదలలేదు, మీరే నేర్పారు కదా మరి ఏదైనా నడమలు వదలొద్దని. పట్టొద్దు, పడితే వదలొద్దు.
అంతే.
పట్టు పట్టరాదు, పట్టి విడవరాదు, పట్టి విడిసిన వాడు పడి చచ్చుట మేలయా విశ్వలా విరామ
వినరవేమ. చాలా బాగా చెప్పేవాడు
చిరంజీవి. మేము ఆన్లైన్ లో ఉన్నామా?
ఉన్నాను సార్, వింటున్నాను.
But this the quiz is very useful for the postgraduates. So if they listen these 2 sessions, very useful. All 10 questions, even we will compile all the pills and the quiz questions and the video recording. Every month we will share.
They can answer 4 essay questions in these 2 talks.
Yeah. Very useful. Five minutes లో ఆటోమేటిక్ గా కట్ అయిపోతుంది అది, అంతే.
మనం ఒకటి స్పెషల్ ఇంట్రెస్ట్ గ్రూప్ ఫీమేల్ జెనిటలీ చేయాలి, ఒకటి
చేద్దాం.
ఇంకా నెక్స్ట్ వీక్
లాస్ట్ 1 minute పీజీస్
ఫిజికల్ చేద్దాం సార్. అది ఫిజికల్ ఉన్న రోజు డర్మనార్ ఉండదు.
అంతేలే, ఎందుకంటే నెక్స్ట్ సండే ఆంధ్రాలో చేస్తున్నారు.
నెక్స్ట్ సండే మన ఇన్స్టలేషన్ సెరమనీ కదా.
ఇలా ఆంధ్రాలో వాళ్ళు ఎస్ఐజి ఫీమేల్ జెనిటల్ నెక్స్ట్ సండే చేస్తున్నారు. మనం ఏప్రిల్ మేలో ఎప్పుడైనా కొంచెం తగ్గినాక ఫిజికల్ గా చేద్దాం.
20 seconds more.
Chiranjeevi, after reading the question answers, then the quiz, the question answer sheet, then the questions from the chat box.
Chiranjeevi, time up.
Yeah, ma'am.
Yeah.
Sir, shall I share the answer screen for
Yeah,
ma'am?
Yeah, you
please
have
share.
to.
Yeah, ma'am. So you can go ahead with the explanation, sir.
Yeah. The answer, which antiviral drug is not likely to cause hypersensitivity reactions? So Marfatia sir has already told, showed nevirapine rash, SJS and everything. So C is the answer. Yeah. Second one, bacillary angiomatosis is caused by Bartonella Hensleigh.
This also Shara shows the image.
Yeah. The organism that is implicated in the development of granulomatous rosacea in AIDS is, Demodex folliculorum. Yeah, oral hairy leukoplakia is caused by EB virus, Epstein-Barr virus. Yeah, fifth question. Which one is not an AIDS-defining illness? So all the other three except persistent oral candidiasis is not an AIDS-defining illness. So what are the vaccine-preventable diseases?
Oroesophageal candidiasis
Candidiasis.
is AIDS. So that's why I accept.
Yeah. Vaccine-preventable diseases, as you know, hepatitis B and hepatitis. HPV, sorry.
Human papillomavirus.
Yeah, human papillomavirus. How soon after sexual exposure HIV disease can be diagnosed by routine tests? Around 6 to 12 weeks. By P24 is the earliest antigen. Yeah. When did HIV infection first detected in USA? Sir, Venkatramana sir clearly showed it is in 1981 in US and in 1986 in Chennai in commercial sex workers.
6 commercial sex workers.
86 and in Chennai. Yeah. Which is not a high risk behavior. So, sir told abstaining from sexual activity, no sex before marriage. Yeah. What is one reason STD often go untreated? Because they are asymptomatic. So they go untreated and they transmit to their partners.
Yeah. So the question answers from the chat box. And even from the quiz also, Venkatramana sir, so Martha sir has some work he left. So you are only one person to able to.
Yes, definitely.
All any from the quiz also you can add anything and
Yes,
for
yes.
question.
Yes.
Chat box.
Yeah, chat box alone. 5 questions are there, sir. You can see.
Post చేయండి.
నువ్వు చదవమ్మా.
Okay. When must we do screening of HIV after PEP treatment from Dr. Sheikh Fawaz Latif?
PEP stands for post-exposure prophylaxis. So when there is an accidental cut and needle injuries or accidental splash into the eyes, after giving a primary first aid like washing with normal saline or tap water, or washing the injured area with tap water, soap water, alcohol, absolutely. My friends, my virus, this HIV virus is a very, very timid virus. It cannot do anything. Tap water will kill, soap water will kill, absolute alcohol will kill, glutaraldehyde will kill, or even the Hyderabad summer in the month of May will kill, just heat will kill this virus. Such a fragile virus, but it becomes a lion once it is stuck with the receptors. That's why we should not allow the virus to stuck to the receptors. Immediately, once we get injured, immediately we have to wash it. So that will be on the ground, not onto the circulation. then immediately, if we are already trying to have a knowledge how to start the PEP, you yourself can assess the risk and start the PEP. If you are not having any training, then report to the senior physician who has been trained and who knows about when to start PEP. This will be decided on the facts, material of facts there, like whether the patient is HIV positive or negative, if positive, on treatment or not on treatment, whether viral load is suppressed or not suppressed, what is the instrument that caused injury, solid suturing needle or hollow IV needle or surgical blade or amniotic splash into the eyes, are there injuries on the gloved hand or a bad hand, or injuries superficial only to the epidermis, or injury has occurred deep into the dermis or the muscular plane, damaging the capillaries and venules. So based on these facts, we have to start or not to start the PEP. Once we have decided, yes, there is a risk, we have to start the PEP. Before starting the PEP, we have to test that particular doctor, paramedical staff, or nurse whether already infection is there or not. We are also human beings. We will have our own weaknesses. That's why whether infection has already entered the circulation or not, we have to document it by testing VDRL, ELISA test, TRIDOT test, HbAg, everything we have to test. Then start PEP. All these things should happen preferably within 2 hours. So if you are able to start the PEP within 2 hours, it is 100% effective, protective. And this PEP has to be taken continuously for 4 weeks. Then you can go for a test. Or if you are testing with antigen detectable lab tests like PCR DNA or proviral DNA, then you can detect it early itself. Then you can stop the treatment if they prove to be non-infected. That's how the PEP has to be given.
Yeah. Going to the second question, sir. Monotherapy with efavirenz in PPT-CT is still useful, from Dr. Vijay Aitan.
Monotherapy is nowhere useful. Nowhere it should be used. It is always multi-drug therapy. Minimum 3 drugs should be there. In that, efavirenz can be there. Now, efavirenz previously thought it will produces the mitogenic effects because of neural tubal defects, but now research has clearly proven that it is there only in the animals, not in the human beings. Now we can happily continue efavirenz containing triple drug regime, not monotherapy. We can continue. Safe, it is safe.
Okay. From Dr. Ramesh Kottari, what is the new approach for HIV patient?
New approach is a test and treat. The moment patient come to us or we suspect, we have to test. We need not wait for till the CD4 comes down, or I am not ready, my wife is not accepting, my husband, I have to take permission from my husband. All these things we have to convince them through counseling and start the treatment early and see that they will be adherence to the treatment regime and their viral load comes to zero, undetectable viral loads. That should be the target, so that the treatment will act as a prevention. That is a TAP, the new approach.
So
Treatment as prevention.
T square, test and treat, new concept. Yeah,
yeah.
good.
Yeah, Arumuga Kani has Dr. Arumuga Kani. Anybody got cured from AIDS, sir?
The two success stories which I told you. These are the two success stories. Yeah, one is Brazil, the Berlin patient, another one is London patient.
Yeah.
These are the two patients who are now cured. Rest of the people, they are under control. These are two success stories.
Dr. Hinal, drugs for PrEP, is it available in India?
Yes, it's available. Only thing is, we are promoting PrP, that is pre-exposure prophylaxis for the discordant couples. Wife positive, husband negative, husband positive, wife negative. So for the sake of pregnancy, for the sake of healthy children, we are promoting that. And at the same time, homosexual relationships also. One partner positive, one partner negative. So under those circumstances, we are promoting it so that the non-reactive partner or an uninfected partner will be using these drugs so that they are allowed normal sexual intercourse for the sake of pregnancy. they won't get infection from the husband or from the partner, and they won't pass infection to the children. That is PrEP.
Yes. Is pre-test counseling and consent mandatory in the present times? And from my side, sir, should we write on the prescription that pre-test counseling is done? Is it from our side to protect ourselves?
Yes, pre-test counseling is a mandatory. Why it is mandatory means there is a opt-out procedure is there in the testing. Patient can having every right to say, I don't want this test. We cannot deny his right. Say, for example, I came you as a patient. You are telling Mr. Venkat, I am advocating these tests. We should not say, go and get these tests. Mr. Venkat, I am advocating these tests. These tests are for these problems. So your present problem maybe is a confusion. So to get a clarity, I am asking you to undergo these tests. So then I can exercise my constitutional right saying that, Madam, I don't want this test. When I say that I don't want this test, then you have to explain, okay, I respect your right, but if this infection would have been there in your body, unnecessarily you will be serving it to the other people in the community. At the same time, it damages your immune system and you will prone for numerous opportunity infections. That's why you rethink yourself and you exercise your right. So that information you have to give to the patient, then leave it. Then you make a note on the OP ticket or a case sheet that if a patient refuses a test, we have explained the consequences.
Before
Result.
test also, we should write, sir, on the prescription, a counseling done to get this test.
And since you are in the teaching institute, you will be protected because there is a separate counselor there for you.
Yeah.
In
private practice, because she's a practitioner.
In nursing homes, in private practice, private hospitals, we have to do everything. That's why you have to maintain a record to avoid legal complications.
Those are the questions.
Result declared.
Yeah,
the
result. Yeah. Chiranjeev?
The
Sure.
most awaited.
Yeah.
Yeah, ma'am. We are presenting the slide.
Yeah.
So I present the result, no?
Hearty congratulations.
Good,
Dr. Harsha from Gandhi Medical College, Dr. Sneha from KMC Warangal, Dr. Hinal from GEMS, Solapur, and Dr. Muhammad Shafiq from JNM Hospital and College, and Dr. Vignesh Narayan from PGI MER. Congratulations to the
Hearty
winners.
congratulations.
Hearty congratulations.
All 5 people. Pancha Pandavas.
Yes.
Congratulations.
One from Gandhi, one from Warangal, one from Solapur, one from
Solapur.
Almost represented entire India.
Entire India. Yeah.
Good. Very good.
And thank you, Telangana Iadvl, Dr. DBN Murthy sir, Dr. Bhumesh sir, Dr. Janardhan, and very happy to hear your lecture, Dr. Venkatramana sir.
These all five,
thank you.
all 5 PGs will receive the gift and certificate soon. So the surprise gift and very, very useful in our day-to-day practice. The immunity kit.
Good.
So
you are giving hand wash?
No. Immunity kit contains surprise.
Okay.
It contains multiple.
Okay.
Over to Dr. Kavita.
Yeah, it was indeed a very great presentation by our Mafatia sir and Venkatramana sir. Of course, the quiz was really good. And the awareness campaign on the steroid for the past 2 years, Dr. Bhumesh sir is continuing and he's still continuing. Hats off to your energy level, sir. And I now request our treasurer of TS Iadvl, Dr. Janardhan sir, to kindly propose vote of thanks.
Am I audible, ma'am?
Yeah.
Yes, sir.
Invisible but audible.
Visible, Gandhi, sir.
My camera is open only.
COVID virus lakkundi kada nani paristhithi.
But you are audible.
Respected President Dr. DBN Murthy sir, our dynamic secretary Dr. Bhumesh, our most valued invited guest for today, and dear Iadvlites. It's my privilege to propose today's vote of thanks on this webinar on interesting topic HIV, AIDS, and STIs. I thank for today's eminent speakers, Dr. Yogesh Marfatia sir and Dr. Venkatramana sir, on behalf of THIADVL for gracing and sharing the important valuable information and experiences on this HIV topic today. It has benefited our fellow colleagues and PGs as well. I also take this opportunity to thank Dr. Satyasri Madam for conducting the quiz for PGs and Dr. Kavita Ma'am for being a master of ceremony. We also hearty congratulations to today's winners. And finally, I would like to thank Hetero Healthcare Group for supporting for today's webinar. Thank you very much.
Thank you, sir.
Thank you. Thank you, one and all.